Good evening, everybody. My name is Peter Siersema, and I share this webinar together with Helmut Messmann, the former president of the ESGE. And this is already the 10th issue of the ESGE Papers of the Month webinar. And we have again 4 exciting speakers, 2 presenters and 2 discussants. The 2 presenters are Professor Anthony Teoh from Hong Kong, and also Dr. Massimiliano di Pietro from Cambridge in the UK. And the discussants for tonight are Dr. Manuel Pérez-Miranda from Spain and also Dr. Miguel from Portugal. And we start now with the first presentation that will be done by Dr. Teoh. It's an exciting paper, I think. It's the DRA-MBO trial, and all the ins and outs will be presented by Dr. Teoh. Please.
Hello, ladies and gentlemen. First of all, I would like to thank ESGE on giving me this opportunity to present the results of this intriguing or even controversial studies comparing EUS-CDS, Choledocho-duodenostomy, versus ERCP with covered metallic stents in patients with unresectable malignant distal biliary obstruction. In short, DRA-MBO trial, which stands for Drainage of Malignant Biliary Obstruction. These are my co-authors. I thank them tremendously for their relentless support, because without their help, this study would not have been possible. Many of them are my very good friends, and they were very kind to help me throughout this study. So as we know, EUS-Guided biliary drainage is traditionally indicated in patients with failed ERCP. However, in recent years, there has been more and more talks on whether the primary EUS-BD can be considered as an alternative to ERCP as a primary way of draining malignant distal biliary obstruction. Of course, the idea is that in EUS-CDS, for example, the stent is placed away from the tumor, so the risk of tumor ingrowth in theory should be reduced, and this may have a potential for improved stent patency. But of course, with any EUS drainage procedure, there's an inherent risk of the procedure. We have to balance the risk versus the benefit of the procedure. The aim of this trial is to compare primary CDS versus ERCP with SAMS in unresectable malignant distal biliary obstruction. We hypothesize that CDS is associated with a higher 1-year stent patency rate, and creation of CDS would reduce the chance of tumor ingrowth. We included consecutive patients admitted for obstructive jaundice due to unresectable primary malignant distal CBD strictures. The patients were randomized to receive either CDS or ERCP with SAMS. We included all patients with histologically or radiologically confirmed primary distal malignant bile duct tumors. They are inoperable by staging. The tumors need to be at least 2 centimeters from the portal hilum, and the minimal bile duct size is 12 millimeters. We excluded patients with the following criterion, in particular in patients with significant tumor infiltration of the first part of duodenum, with thickening of tissue more than or equal to 8 millimeters were excluded. In terms of study interventions, CDS was performed by an 8 millimeter or 6 millimeter quadri enhanced lamps. The lamps could be inserted by either the conventional method, requiring needle puncture and guide wire insertion, or the direct method, which involves direct insertion of the quadri enhanced delivery system. For the ERCP arm, a partially covered SAMS was used because from the literature, it seems that this type of stent is associated with the highest patency rate. In an event of failure of intervention, the patients were allowed to cross over to the other study arm for an attempt to endoscopically drain the bile duct. In patients with duodenal obstruction, particularly in the ERCP arm, if there's difficulty on inserting of the duodenal endoscope, the endoscopist should attempt to dilate the stricture to allow insertion of the duodenal scope. Mind you, none of these patients have clinical presence of GOO. So all these duodenal obstructions were discovered only on ERCP. Outcome measurements. Primary outcome is the 1-year stent patency rate. Stent dysfunction is defined as radiological or endoscopically confirmed stent obstruction. The secondary outcomes included technical and clinical success rate, adverse events, time to stent dysfunction, reintervention rates, as well as mortality. So in terms of sample size calculation, for the SAMS arm, amongst 4 randomized trials that compared stent patency between covered and uncovered SAMS, the mean 1-year stent patency rate of the covered SAMS in these trials were around 67%. We assumed a 20% difference in 1-year stent patency rate between the two study arms, 87 versus 67%. 73 patients were required in each group. And taking into account the 10% dropout rate, 82 patients would be required in each group. Results. During the study period, 164 patients were recruited, 82 in each arm. In the ERCP group, 3 patients have failed randomization due to a computer error. 4 patients received surgery after chemotherapy and were excluded, 1 in the ECDS arm and 3 in the ERCP arm. 3 patients in the ECDS arm were lost to follow-up. Finally, 79 patients in the CDS arm and 76 patients in the ERCP arm were included for analysis. These were the background demographics. There were no significant differences between the two groups. Diagnosis, majority of patients had pancreatic cancer. Length of tumor is around 3.6 centimeters. The bile duct size is around 16 millimeters. And the reasons for inoperability were locally advanced cases and also presence of distant metastasis. In terms of the technical success in the ECDS arm, it was significantly higher in this group, amounting to 96% versus 76%. Amongst these patients, the rate of duodenal obstruction were similar between the two groups. In the ERCP arm, the causes of failed cannulation included duodenal obstruction as well as failed cannulation. In terms of clinical success, there were no significant differences. In terms of procedural time, it was significantly shorter in the CDS arm. However, if you look at the stent patency rates, there were no significant difference in the stent patency as well as the 1-year stent patency rates. For both study interventions, the patency rates were very high. So 91% in the CDS arm and 88% in the ERCP arm. In terms of the causes of reintervention, if you look at tumor overgrowth, it was 99.2% in the ERCP arm versus 3.8%. This was not significantly different, although there's a tendency to higher tumor ingrowth or overgrowth in the ERCP arm. But in the CDS arm, there were other causes of reintervention, like food infection, ascending cholangitis, stent migration. And in terms of readmission, they were not significantly different. And survival time, again, similar between the two groups. So again, the technical failures in the ERCP arm, 5 due to duodenal obstructions, and 13 had failed cannulations. And in the CDS arm, 1 had significant duodenal varices, which prevented puncture. 1 patient had an unstable scope position, and CDS was not possible, and 1 patient had misdeployment requiring PTBD. In terms of the 30-day adverse events, it was not significantly different between the two groups. In the ERCP arm, the rate of post-ERCP pancreatitis was only 2, and 2 patients were both mild pancreatitis. So this is the Kaplan-Meier curve showing you the comparison of stent patency. There were no significant differences in the stent patency rates. And in terms of survival, in both groups, the survival was very poor after 1 year. So in conclusion, ladies and gentlemen, both procedures could be options for primary biliary drainage and unresectable malignant distal biliary obstruction. ECDS was associated with higher technical success and shorter procedural time than ERCP. There were no significant differences in patency rates between the two groups. And primary CDS may be preferred when difficult ERCPs are anticipated, particularly in patients with significant edema, friability in the second portion of the duodenum, malignant infiltration of the ampulla, and also duodenal obstruction. Thank you for your attention.
Good evening. It is a real honor and pleasure to share these papers, ESGE paper session with Professor Teoh about the trial led by him and his team, the DRA-MBO trial. To summarize Professor Teoh's study findings that he just presented to us, 160 patients were randomized with malignant biliary obstruction, were randomized to either EUS-Guided Choledocho-duodenostomy or ERCP with covered Stent. Technical success rate was significantly higher at 96% in the Choledocho-duodenostomy group, so was significantly shorter procedure time at 10 minutes versus 25 minutes. However, the 1 year stent patency rate was no different, around 90% in both groups. Interestingly, the 30-day adverse events was the same, around 16% in both groups. The rate of reinterventions at 1 year was the same again, no differences, around 12%. This is the first large randomized trial comparing hot lamps for biliary drainage to ERCP. It is an adequately powered international multicenter study on a very significant clinical outcome, the 1 year stent patency rate. Comparing this trial to the 3 prior ones, the first thing that catches the eye is the number of patients. The 3 previous trials were smaller, with 14, 34, or 61 patients on each arm versus this adequately powered randomized trial. The next thing that is a little bit different is the type of stent, where we are using lamps, where Professor Teoh's group used lamps. We see standard Stents, and even in some trials, the type of stent was not standardized. However, despite these differences, the high technical and clinical success rate are the same, with some variations in the incidence of adverse events. These 3 trials are in keeping with Professor Teoh. So EUS-BD as a primary drainage option is equal to ERCP. What is the newest thing in this trial is the type of stent used. Instead of traditional Stents, the Lumen Apposing metal stents or lamps were used. These stents significantly simplify procedure time. This is a recent retrospective multi-center French study, and look at the procedure time with comparable high technical success rate. Interestingly, in this French study, both expert operators and non-expert had similar outcome measure regarding procedure time, technical success, and clinical success. So in the current study, when we look at the technique description, we find that the placement of a coaxial double pigtail stent inside the lamps was left at the discretion of the endoscopy. This is a measure that is sometimes used to facilitate stent alignment that we will comment. Other comments that are relatively of minor relevance is the relatively low technical success rate of ERCP, considering that only expert operators were enrolled. This hints to possibly a low threshold to converting for EUS-BD for operators that were qualified in both procedures. Again, the high patency rate of the partially covered stents used in the ERCP group is slightly different from the findings in previous study, but I would say this is the current standard because fully covered or totally uncovered stents have both migration, respectively, migration or ingress rate. So this is the best, possibly the best state-of-the-art stent in the ERCP. Finally, we will look at the inclusion-exclusion criteria, whereas patients with malignant duodenal obstruction were not excluded, and these were only, it is true, incidental duodenal strictures. Patients in whom ESGE, choledocho-duodenostomy, was challenging from an anatomic standpoint were excluded. Again, this might introduce a little bias in favor of EUS. The 3 points that I would like to discuss today is the use of coaxial pigtail stents in the choledocho-duodenostomy group in this study, the common bile duct diameter, and what will be the applicability of these findings to the current MBO population that we see every day in the ERCP room. Let's focus on the coaxial pigtail. So the idea of using a coaxial pigtail is to straighten the angle between the lumps and the common bile duct, because immediately after deployment, this angle tends to be 90%, which would favor sludge formation, stent dysfunction. However, a coaxial double pigtail anchors the stent and makes it correct the axis and makes it look upward. And the conflicting data about the value of this technique, the pigtail through the lumps, but this is a recent randomized trial presented by Dr. Gornaus at DDW, and we see that in 84 randomized patients, the recurrent biliary obstruction rate was only 10%, very similar to the 12% found in the Drambo trial in patients with a pigtail versus almost 30% in patients with no pigtail. And other parameters were in keeping with that, like the rate of biliary reintervention or the time to recurrent biliary obstruction. And in the Drambo trial, we don't know how many patients had a pigtail. The second point for discussion is the common bile duct diameter. This, I remind you, was around 16 millimeter in both groups. And we know from a very large prospective study that including more than 500 patients, that when we examine on EUS patients with pancreatic cancer and malignant biliary obstruction, only half of them have a bile duct of more than 15 millimeter, and whereas a bile duct above 12 millimeter is around 80%. So these are clearly patients that are selected. The other issue relevant regarding the diameter is these, at least in patients with duodenal strictures, the diameter, a smaller bile duct diameter is a risk factor for stent dysfunction, which is relatively low in the Drambo trial. So this may have explained these excellent results. And finally, my third and last, question is, what's the applicability of these findings to the current MBO population? Just to let you know, a large number of patients were screened for eligibility into the trial, and together with very straightforward exclusion criteria, most of the patients, over 500, were excluded from randomization because they were thought candidates for neoadjuvant treatment, which is a very common clinical scenario today. So we know lumps are equal or better in patients with duodenal stricture with difficult ERCP, as Dr. Professor Teoh's conclusions. I totally agree. However, these patients, patients that are only candidates for palliation, are a minority of the current MBO population that we see at endoscopy. And that's it. Thank you very much for your attention.
Thank you very much for the two presentations, Anthony, from you, the paper itself, and also Manuel for the thoughtful discussion. What I forgot to say is that for you, Anthony, it's now right after midnight. So you did us a real favor to stay out of bed and to join us tonight. And I think that's fantastic. And I really like to thank you for this.
Yeah, no worries. It is 1 a.m. here, but it's okay.
Well, fantastic. Thank you very much. And for the audience, maybe we also have a Q&A box. So if you have any questions for Professor Teoh or for Dr. Pérez-Miranda, please join us in the discussion. And if you write down your questions, we can discuss them also during the next 10 minutes. Well, there are 3 discussion points, and Manuel, maybe you can go over those 3 discussion points and discuss this with Dr. Teoh.
Yes, the first is the use of coaxial pigtail stents through the lamps. I would say from the patency rates and the reintervention rate and stent dysfunction rates, that probably a lot of pigtails were used in the Choledocho-duodenostomy patients group. And this is relevant to know because if we choose to go for Choledocho-duodenostomy as primary biliary drainage in patients with unresectable distal MBO, we need to know whether we have to place the pigtail, we have to increase a little bit procedure time and maybe a little bit complexity, or on the contrary, there were no pigtails and it is okay to just place the lamps and leave it at that.
Yeah, thank you, Manolo, for your question. So when we started this trial, maybe 5 years ago, so we didn't know whether pigtails were useful or not. But we did know was when you are placing lamps, actually, we really want, there are 2 ways. You can do a direct puncture, but a lot of time when you do a direct puncture, when you puncture into the bile duct, you're very perpendicular to the opposite wall, which means the stent opening would be smack at the other side of the wall. So in this scenario, I think by placing a pigtail, it does really help in terms of angulating a stent. But for us, actually, we prefer most of the time to do it by the conventional method. So we will insert a needle and try to have the delivery system more at an angle. So after you deploy the stent, it's more at an angle. So for me, in this way, the stent is facing upwards more. And at the same time, there's a lower risk of the opposite wall hitting onto the stent, causing obstruction. And I did look at the data. Actually, the rates of pigtail insertion was only 10%. So actually quite low. We also have experience of placing pigtail stents into the axials. And these pigtails are like, 2-3 millimeters. And if you place a stent of this size into a 6 millimeter stent, actually the lumen is quite narrow. So we actually had cases where the pigtail got obstructed and obstructed the entire system. So I think this angulation of the axials is important. And in very dilated bile ducts, if you do a direct puncture, then maybe a pigtail is useful.
Okay. So before you carry on, maybe I can ask you a question about these Lumen opposing metal stents, Anthony. Do you think there will be a difference between the different Lumen opposing metal stents that are currently available? You use the stent that you used in this trial, but there are now also other stents available. Do you expect that will change your way of using the pigtail stents, or will it change the results?
Yeah, so I think for the newer Corey enhanced lamps, which include other companies, some of the design is a little bit different. For example, the Spexes that requires a infolding of the stent, you actually need a very dilated bile duct. Otherwise, the stent may not fold on itself. And if it just remains unfolded, sometimes the stent can be obstructed. So yes, I think the design of the stent does affect the outcomes. So it may not be applicable to every single lumen opposing stent.
Thank you, Manuel. Please.
There's a question from the audience about the distance sometimes between the bile duct and the duodenum may be longer, and that short lamps may not be adequate. However, looking at this trial and others, no patients were excluded because it was an exclusion criteria, but it never applied. There was only, if I remember correctly, one exclusion due to duodenal varices, another to scope instability, and another misdeployment of patients that were failed CDS, but never because of the distance was too much for a LAMS. And that's also our experience, that we almost never find cases where we cannot perform CDS because of the distance. There might be instances with duodenal infiltration in the bulb preventing a stable position, but not in other instances. I don't know, Anthony, what do you think?
Yeah, I agree. Usually the distance between the bile duct and the duodenum is very small, so it's very uncommon to have a very long distance.
Okay.
Okay, let's move to the next discussion point.
The diameter, the mean or median diameter was 60 millimeter in your trials. Exclusion criteria was a bile duct diameter less than 12. And in theory, this should have happened at least in around 20% of patients. It didn't happen, maybe because you selected patients with a greater disease burden, because a lot of patients were excluded for neoadjuvant. And maybe that's the reason that despite an only 10% pigtail use rate in your, you had such a good patency results and such a low reintervention, because your patients had a really large bile duct, and this is not representative of the whole MBO population.
Yeah, I don't know. When you have obstruction, I think most of the bile ducts would be dilated, right? So unless you really see them very early, then perhaps it may not be so dilated. But yes, these are advanced cases. They are excluded very often because they have metastases or peritoneal metastases, so they were not considered for neoadjuvant. So yeah, this is the inherent design.
Okay, so on
and then the final discussion point, maybe.
Yeah, so around 700 patients were screened, and close to 600 were excluded because they were deemed candidates for neoadjuvant treatment. So the question is, because these are going to be patients that we most often find at ERCP or at EUS-FNA plus drainage with EUS, do you think with the DRA-MBO trial findings and previous studies that Choledocho-duodenostomy can be used as a primary drainage option in patients, in the majority of MBO patients that are going to have neoadjuvant treatment? Or do you think that more data are needed before this is considered a proper indication for primary choledocho-duodenostomy?
Well, I think this is definitely the idea for the next study, because it brings into question whether we should drain with US patients who are potential operative candidates. So definitely there are two schools of thought. I've heard people saying, after a CDS, a straightforward CDS, surgery actually is not more difficult. There is minimal adhesions around that area, and so some surgeons wouldn't mind doing them. And of course, there's the other side of the coin where surgeons are really against us doing US CDS in potentially resectable patients. So definitely up for discussion. My view is if it's a straightforward CDS without any bile leakage, I think it shouldn't cause a lot of adhesions and shouldn't affect the surgical field too much. But definitely this can be, I think maybe some studies are already on the way to address this question.
Okay.
May I ask a last question, Peter?
Yeah, there's a last question. Is there a difference between the two approaches about patient survival? But I think you showed that already. There was no difference in the survival between the two modalities, huh?
No, I thought I have a question, Peter.
You have a question. Well,
Yeah.
there's one question in the
Is it allowed?
Of course, my friend. Come on.
No, Anthony, you showed us there's no big difference or in favor of the CDS drainage for clinical data, but what are your thoughts about cost or the CO2 footprint? I mean, ESGE has published a position statement on green endoscopy, and this will obviously also influence new technologies. So any thoughts? I think you didn't analyze it, but what is your comment on this topic, costs and CO2 footprint for this procedure?
For now, I think as CDS with the hot axial is definitely more expensive. But as we see more and more new cochlear enhanced lamps become available in the market, I think the cost definitely it will come down of the stents. And with this, I think the major cost right now is still the cost of the stents. So definitely there might be pressure for the companies.
Okay, thank you.
But you only use one endoscope for diagnosis, staging, and tissue sampling and drainage. Saves reprocessing. And
so this is in favor of
CDS.
footprint. You're right, Manuel.
Also, procedure time is shorter.
Yeah. Okay. Brilliant.
Okay, friends, that's fantastic. I think we had a very good discussion. I think we have to move on also because of the time, because of the second speakers that are waiting. So, Helmut, maybe you can introduce the second.
You already introduced. So
thank you very much again, of course.
The next paper is now a paper on the Barrett's. Is published in Endoscopy, the effect of procedural time on dysplasia detection rate during endoscopic surveillance of Barrett's esophagus. It's presented by Massimiliano di Pietro from Cambridge, and the comment will come from Dr. Miguel Araya from Porto. So let's start with the presentation first, please.
A very good afternoon, everyone. It's a great pleasure to take part to this exciting webinar, and thanks to the ESGE for the opportunity to present today the results of our study. My name is Massimiliano Di Pietro. I'm one of the gastroenterology consultants at Cambridge University Hospitals and clinician scientist at the University of Cambridge. I'll be presenting today a paper on the effect of procedural time on dysplasia detection rate during endoscopic surveillance of Barrett's esophagus. I have no conflict of interest to disclose. So as many of you will know, Barrett's esophagus is the only precursor lesion to esophageal adenocarcinoma with a transition to cancer which occurs in about 0.3% per year of patients with Barrett's esophagus. Most of the clinical societies, specialist societies, recommend endoscopic surveillance for Barrett's esophagus, which is usually done using the Seattle protocol, which entails 4 biopsies every 2 centimeters in the Barrett's esophagus. However, Seattle protocol is renowned to be time-consuming and inadequately performed in clinical practice. This is data from US, from pathology national databases on over 2,000 endoscopic procedures, which shows clearly that the adherence to the Seattle protocol decreases with increasing length of Barrett's esophagus, which is also related to higher cancer risk. And the adherence to Seattle protocol was only just over 10% in Barrett's of 9 centimeters or longer. There is some evidence that the inspection time correlates with the detection of dysplasia. This is again, data from US, from a multicenter trial, which shows that increasing inspection time correlated both with detection of suspicious lesions and high-grade early cancer lesions. However, in this study, investigators included patients with visible lesions on endoscopy, which could have impacted on the inspection time. The aim of our study was to investigate the optimal procedural duration of Barrett surveillance with adequate biopsies, and also to establish the impact of variables such as Barrett's length, procedural duration, endoscopist experience on the dysplasia detection rate. We used data from a crossover randomized trial published last year called ESGE trial. In this trial, patients with Barrett's esophagus, at least C2 or M3, and no visible lesions were randomized to receive either an experimental endoscopy with autofluorescence imaging, confocal endomicroscopy, and molecular biomarkers on targeted biopsies, or gold standard white light endoscopy with Seattle protocol biopsies. And they crossovered after 8 weeks to the alternative arm. In the study published in Endoscopy, we used data only from the standard arm. So we included all the patients that had endoscopy as part of the gold standard arm, white light endoscopy, with targeted biopsies and Seattle protocol biopsies. I have to stress that the endoscopists that performed these procedures were blinded to the diagnosis of the other procedure as well as the referral histology. And this trial was performed at 2 tertiary referral centers. So these are the demographics of our cohort, 142 patients with a mean Barrett's length just under 6 centimeters. 3/4 of these patients had no dysplasia, and about 20% had either low-grade, high-grade, or early cancer. In this trial, the mean number of biopsies was 12.4 per patient. The mean number of targeted biopsies was 2.5, and the mean number of Seattle protocol biopsies was 11.3 per patient. So moving on to the results, on the left, you can see the procedural time in 3 tertiles, 2 to 5 centimeters, 6 to 10, and 11 or more. As expected, we had increasing procedural time, 14 to 17, finally 20 minutes in each of the 3 tertials, and this difference was statistically significant. The overall mean procedural time was 16.5 minutes. Moving to the graph on the right, we can see the number of biopsies. In particular, we use the number of biopsies per 2 centimeters, where 4 would be adequate as per Seattle protocol. And you can see that the endoscopies perform pretty well with an average number of 4 in each of the 3 tertials. So there was no drop in long segment of Barrett's, although there was some variation, especially in the shorter Barrett's segments. So moving on to the correlation between variables and dysplasia detection rate, we looked at the factors like endoscopy's experience, Barrett's length, and procedural time. The only variable which was significantly correlated with the dysplasia detection rate was the procedural time. In particular, we found that on the whole cohort, there was a correlation between procedural time and dysplasia detection on Seattle protocol biopsies. And this was independent of endoscopist experience and Barrett's length. Interestingly, we found no correlation on the whole cohort of procedural time with dysplasia detected on all biopsies and targeted biopsies only. So the conclusion was that we found a 10% increment of dysplasia detection per additional minute of procedural time on the random biopsies. We wonder whether the length of Barrett's could have played a role. Therefore, we looked specifically at the group of patients in our cohort with Barrett's length of 6 centimeters or more. So the 2 tertiles on the right that you saw in the previous graph. And we looked at 58 patients, 15 of which had any degree of dysplasia. So in this analysis, interestingly, we found that the procedural time was correlated with the dysplasia detection rate on all the biopsies. So namely on the left, all biopsies, in the middle, targeted biopsies, and on the right, Seattle protocol biopsies. With a 21 to 25% incremental dysplasia detection rate per minute, per additional minute of procedural time, suggesting that in patients with long segment of Barrett's, longer procedural time significantly correlate with detection of any degree of dysplasia. So, ladies and gentlemen, in conclusion, in this study, we found that the average duration of a Barrett surveillance procedure with adequate Seattle protocol biopsy was 16.5 minutes. We found that overall, longer procedural time correlates with dysplasia detection rate on random biopsies, suggesting that the time taken to take random biopsies does impact on the dysplasia diagnosis. Finally, in patients with Barrett's Barrett's esophagus 6 centimeters or longer, we found at least a 20% incremental rate of dysplasia per additional minute of procedural time, both on targeted biopsies and random biopsies. So really, to me, the take-home messages of this study are that, first of all, we need to allow sufficient time for a Barrett surveillance procedure. We calculate that for Barrett's esophagus 1 to 5 centimeters, this should be at least 30 minutes, and increasing to 40 centimeters for Barrett 6 centimeter or longer, accounting for preparation time, reporting time, and time to inform the patient about the procedures. And our data are in support of the knowledge that at least 1 minute of extra time per centimeter of Barrett should be used for these procedures, and this should be included in the future guideline recommendation. Thank you very much for your attention, and I'm looking forward to the discussion.
Dear colleagues, my name is Miguel Areia. I'm from Coimbra, Portugal, and it's a pleasure to participate in this ESGE webinar regarding this article produced by Dr. Pietro and colleagues. I have no competing interests to declare, and the things of the study, in my opinion, are that this was a prospective study with a very strict protocol data coming from a randomized control trial made in 2 excellent expert centers, and they used for the measure of the time for Barrett's inspection white light endoscopy only. So the time that was used for the endoscopy was not due to any additional thing to just white light endoscopy. The robustness of the results are quite impressive. The mean procedural time for any upper endoscopy inspection for Barrett's were 16.5 minutes. This is in contrast what is said to give more than 7 minutes for a normal, regular diagnostic exam. Consistency of the results was consistent among subgroups. When they divided the groups of Barrett's according to the maximum length of Barrett's in 3 groups, we see that the time increased by the increasing of the Barrett's length from 14 to 17 and even to 20 minutes for the longest ones. But still, the use and the application of the Seattle protocol kept with time and with Barrett of length, because the number of biopsies per 2 centimeters of Barrett's were always around 4, which is, we know that is the normal number of biopsies that we should do, but we also know from other studies that we tend to lose this amount of biopsies on the longest segments. And also the main result, the incremental dysplasia rate that was gained and obtained by initial minute for inspection, was adjusted for two very relevant variables, the Barrett's length and the experience of the endoscopist, and the results stood and kept even including these two additional things that we know that influence the incremental dysplasia of Barrett's per additional minute. Also, in my opinion, one of the strongest things of this study is that the final result, the inspection time during the Barrett's endoscopy, is a quality measure, already known, already reported, and it's very easy to perform and to report. And also, additionally, it does not add any additional cost to the procedure. It doesn't require any additional training, and also does not require any additional equipment. And that's why eventually this is not so appealing as other things, and that's why this is not so published as other things that we do, that we see in our daily practice. But this is, although might be not appealing, maybe it's more relevant than other things that we see published and talked about. Some weaknesses of the study. Well, dysplasia detection was not the primary outcome. This is a post hoc analysis of a randomized trial for other issues. So eventually it might be not the best way to get this primary result. The results came from two very expert centers, so the generalization of the findings might not be so generalizable as we would like to. And also, it was not a specific record on time for Barrett's inspection. As the authors state in the manuscript, they recorded the full-time inspection for an upper endoscopy, which is right, but they don't separate what was the time spent in the Barrett's and the time spent in the rest of the inspection. So we assume that in a normal inspection, they took around 7 minutes to see the esophagus, the stomach, and the duodenum, and the additional minutes were for the Barrett's, but we don't have these two times separate, so because there was not a specific record on time. Comparing with other studies already published, these are two relevant studies that I think we need to talk about in this presentation. There was already more than 10 years ago a published study similar to this regarding the inspection time and the detection of dysplasia and carcinoma, and by then, they reached the same conclusion that if you separate people that took less than 1 minute per centimeter of Barrett's, for those that took more than 1 minute per centimeter of Barrett's, it was an impressive and statistically significant difference in the rate of detection of suspicious lesions and high-grade dysplasia and cancer. This was more than 5 times the rate of detection. Another relevant article, in my opinion, which is a little bit different, is not the time of inspection of Barrett's, but the time slot that you take for scheduling a diagnostic endoscopy. And they compared the usual 15 minutes in this specific issue and country to an increased 30 minutes slot just for making an upper GI for surveillance of Barrett's. And what they see is if you get more time to do what you need to do, you will use more the prior classification, you'll do more the right Seattle protocol, and also you will detect more dysplasia just by giving more time for people to use more time to do the inspection. Well, application of these findings, since 2016 that the European Society already published the quality parameters for upper GI, and by then we said that you should look at inspection time just for Barrett's esophagus as a minor performance measure. And by now, you have the ESGE quality check application that you can use if you are a member of the ESGE for free, and you can use it to measure your own quality. And one of the questions that you will have there, if you are doing an inspection of a Barrett's, among other things, and Seattle protocol, will be the time that you spend by centimeter of Barrett's. So use the application and see if you are following all these relevant things that are coming published in the literature. My final slide, some questions for Dr. Pietro and colleagues.
Okay, so Dr. Pietro, some questions I would like to pose you before we have some questions from the audience. I think so. I hope so. So, in your opinion, with your results and what we have published in literature, what do you think it's the best allocation time for a regular diagnostic endoscopy, if you don't know the pathology that the patient might have?
Yes, I think you have mentioned the results of the previous studies that at least 7 minutes should be dedicated to the actual endoscopic procedure on any diagnostic list. This time is not just about spending time hovering around the stomach and the esophagus. It's the time that you use for cleaning your endoscopic field and take good photo documentation. With the photo documentation is essential not only to document your finding, and we are all very much used to radiologists using images to document their report, but also to train yourself in taking good quality endoscopic pictures. And I always mention to my trainees that they should strive to take good quality endoscopic pictures, because this is the elements that will drive their attempt not only to clean the endoscopic field, but also to inspect all the parts of the stomach and the esophagus in line with the recommendations and take good quality endoscopic pictures, which means achieving good quality imaging. So 20 minutes should be the allocated time for a diagnostic endoscopy.
Yeah, fully agree. I think that everything that is below 15 or 20 minutes will not be enough for us to do a good job, even for what you call a simple diagnostic endoscopy. For the second question, I think you already answered in one of your last slides, but I would like some comment on that. So the best allocation time for a Barrett surveillance endoscopy, so you know already that the patient has a Barrett, but you want to surveil it. So you talk something about 30 to 40 minutes. Do you think it's feasible, especially if you have dedicated sessions, for instance, just for these patients, instead of being a Barrett's among other things that you have to do in that day?
I think it's the challenge that all of us have with the department, and the ratio between quality of our endoscopy and the income. But if you take that in a 20-minute slot, 7 minutes should be the minimum for a diagnostic endoscopy, and you take the 16 minutes of our median average procedural time for Barrett's, it means that if you add those 30 minutes of extra time for a standard endoscopy to the 16.5, you easily get to 30 minutes. So 30 minutes should really be the minimum for a surveillance endoscopy. And it's not only Barrett's, it's also gastric atrophy, patients with family history or conditions that predispose to gastric cancer, for example. But then if you go on very long segment of Barrett's, we clearly show that, the time increases, and that becomes, so the procedural time becomes 20 minutes. So if you add those extra 30 minutes, you easily get to 40 minutes. And if you want to do a good quality procedure, which justifies the money that the government pays for an endoscopy, or the patient itself, or the insurance, we have to ensure that our time is properly used, and we give the right type of service for this patient. So I think the next set of guidelines should clearly give us some directions as to what a surveillance procedure should last. And I think at least 30 minutes, moving to 40 minutes for very long segment of Barrett's.
Yeah, and I hope that in the next update of the quality guidelines, we will make some statements on the time for the procedures, hopefully.
So maybe you can add to that. Maybe I can interrupt for a second, because there's a question from the audience. Was a transparent cap used for Barrett's inspection, and would that have influenced the detection rate of dysplasia? Maybe for you, Massi, but also for Miguel. What do you think?
We did not use a transparent cap. This is usually used only for therapeutic procedures in our institution.
Yeah, I have the same feeling. So I know this is not for everybody to agree, but I don't think that the cap in the esophagus for a diagnostic surveillance is so necessary. I think, as Dr. Pietro showed, time and care is more relevant than using the cap, but that's my feeling.
Okay. What is your recommendation regarding acetic acid, Massimiliano?
Well, obviously we are all familiar with the data on imaging, there is no definitive evidence that any advanced imaging actually increases the dysplasia detection rate. That doesn't mean that does not help. We don't have, formal proof. I think any form of advanced imaging that you throw in the algorithm will help. And MBI, especially the latest generation from the EVIS-X1 MBI, is an excellent tool. Acetic acid also helps. I think what we have proved with this study is that it's simply the time that you take to do a good quality procedure that will impact on the additional incremental rate for dysplasia. But I do believe that when properly trained, endoscopies can use advanced imaging to help that self picking up extra lesions.
I'm a believer in acetic acid, and the other trial convinced me really that it is helpful. But there's still other. Time is for sure a more important issue. I agree. But let's continue with the other questions now.
Yeah. Okay. So, Dr. Di Pietro, do you think so? As you told, and I mentioned it already. So this was not the main outcome. This was a post-hoc analysis. Do you think we still need a prospective study just with time as an outcome, or your data are so relevant by now that it should be enough?
I think this will be a tricky task, because there is an effect of trial on the operator, whereby the design could be to randomize patients to either receiving an endoscopy with at least pre-specified inspection time, so 1 minute per centimeter, or to the endoscopist's judgment. But inevitably, when endoscopists are in a trial, they will always perform better than in routine clinical practice. So even though, yes, you could design such a trial, that might not lead to the desired outcome simply because there is an artifact of an investigator being monitored.
Yeah, so I made you the question, but in my opinion, I think this is already the answer. So I think a trial randomizing trial even will be quite discussable to make that kind of argument. And another tricky question. So, and what about the prospective study outside expert centers? Because this is also if you feel that this kind of patients, so we are not making a diagnosis of Barrett's, but a surveillance of Barrett's, that this should be done outside expert centers, or this should really be moving to expert centers and dedicated people and staff?
Yeah, obviously, ultimately, it is important to gather data from, the routine practice outside very expert centers. I think one thing which is most relevant to me is actually to understand whether Barrett surveillance should be done in expert centers or can be done by anyone. There is some increasing data that outcomes, and I'm talking about hard outcomes in terms of, not only dysplasia detection, but also mortality from cancer, post-endoscopy, Barrett's neoplasia, improves in expert centers. And in fact, actually, we have now prospective data that clearly shows that when the surveillance is done by expert endoscopists who are trained to use advanced imaging and apply in a strict methodology, the Seattle protocol, not only the dysplasia detection rate increases, maybe as far as 4 times the data published in the literature, but also the overall mortality will reduce. So I think this is something that I would like to see in the next future, as to whether actually the hard outcomes, such as mortality by esophageal adenocarcinoma, improve when the surveillance is done by expert.
Yeah.
Before we come to the last question, which is a tricky one, there's a question from the chat. Is deep sedation and the use of simeticone just before starting the procedure necessary?
I don't think a deep sedation is necessary. So the majority of the patients will do well on conscious sedation. We generally use a combination of midazolam and fentanyl. Obviously, there are some patients which are intolerant even to that, in which case you escalate to deep sedation. Simeticone might be very good for stomach. but not necessarily necessary for esophagus. Often you do need water jets in order to really make the most of your cleaning abilities.
Thank you. And now we came to the last question, Miguel, which is a very tricky one.
Yes, so
it's
the
also
last
interesting.
Might be a little tricky one. So, but as Dr. Di Pietro also said, so surveillance endoscopy for Barrett should be different from in time schedule for a regular diagnostic endoscopy. Even for a very long Barrett should be different for a shorter Barrett. So, do you think we should, as a society or inside our countries, have some discussion regarding reimbursement by time instead of by diagnostic procedure, so that we have to explain to people that are paying for our job that making 40 minutes endoscopy for a Barrett surveillance is not being lazy, but it's doing our best, and this should be the best for the patient instead of paying just for 20 minutes endoscopies.
Well, I mean, I think it's difficult to really make reimbursement by time, but I think at the very least there should be a distinction between a standard diagnostic endoscopy and a surveillance endoscopy, because surveillance endoscopy is not just about the time, but it's the expertise, is the time of the pathologist to look at biopsies, is the consensus review in case of dysplasia diagnosis. I think surveillance procedures have to have the right quality. And if this is done in the right setting, they have to have a different reimbursement.
Okay, fully agree.
Okay. Great, thank you. And no other questions in the chat. Maybe a last question to both or to all three of you. In your country, how or in your institute, how long do you plan for in a patient who gets an upper GI and lower GI screening endoscopy? How long do you usually plan in your units versus combined procedures? If a patient comes up for a screening, let's start.
Well, I mean, in Cambridge, I have agreed with the department that patients coming for surveillance of long segment of Barrett's and gastric atrophy, they get a double slot, which is 40 minutes.
40 minutes and additional colonoscopy in the same patient? How long? If this happens?
I don't do lower GI anymore.
So
I would let the other colleagues to answer.
Miguel, how is it in your country?
So I just work in an oncology hospital. So many of our patients have pre-malignant conditions. So we schedule every upper endoscopy for 30 minutes.
30 minutes for upper.
30 minutes for every upper endoscopy.
And for lower GI?
And for lower GI, we have 45 minutes.
45. Okay. Peter? Finally, Netherlands?
More or less the same. So we have half an hour for surveillance, and especially when of course, the segment is a little bit longer, and that's the majority of patients that we see in our hospital. And then for colonoscopy, we schedule depending on the indication, of course, and the let's say the expected difficulty between 35 and 45 minutes.
Okay. Interesting.
And what about Germany then?
Good question. I think it depends really. Outpatients sometimes very half an hour both, I've heard. Not in my unit. I don't do screening in my unit. But this is very short, I would say. In Japan, I talked to Oyama, my teacher. He says 7 minutes for upper GI, which is quite short. I thought Japanese are so precise and take half an hour.
Yeah, that's I would think as well, yes.
About 10 minutes upper GI. It's interesting. So time is crucial, but obviously time in different countries is also different.
Different, yeah.
It's relative, everything. Okay.
I think in Japan, they do most of the procedure without sedation at all.
Exactly.
It makes obviously things a little bit easier in terms of flow of events in endoscopy. Perhaps they have a different patient population.
Okay. I think we are almost at the end and a bit over time. So thank you very much, Massimiliano, Miguel, Manuel, and also Anthony, who hopefully sleeps now.
I hope so.
It was a pleasure to have you here with your wonderful presentation, with your papers and your fruitful discussions. Yeah, and now we stop here with our last slides. You see, ESGE is a big society. Meanwhile, we have more than 4,000 members and are still growing. So those who are not still members, you should become members. There are so many advantages. So please go to our webpage and look for all the advantages you can have. Next slide, please. And you see the ESG Days 2023 are still ongoing because you have a chance that until the June of 13th, you can visit all sessions which were streamed. So from every topic, free paper sessions, guideline sessions, live endoscopy. And we had an analysis today, and it's really thousands of people are still using this option. And the next slide, this is now the most important message. After the Congress is before the Congress. So please become member, and then you can register very, very cheap for next year. It's in Berlin. It's our Jubilee Congress. We are now 60 years old as a society. So, and I think it will be a wonderful meeting in Berlin. And yeah, would be happy to see many of you. Fellowship grants, don't look at the deadline approaching tomorrow. I mean, if it's a couple of hours later, we still will accept your applications. And the last slide, finally, next week we have, again, ESG Days. We will report the best abstracts of core endoscopy, ERCP, and EUS, and presenters will be Pierre Dupré and Pérez-Miranda. So thank you. And that's it from my side. Thank you to David and Gabi on the back side of the backstage to support us always, Peter and me. And now we wish you all a nice evening and enjoy the rest of the day. See you next week for the next webinar. Thank you.
Thank you very much.
Bye now.
Bye-bye.
Good
night.
Bye-bye.
Everybody.
Good night.